Welcome to Speaking of Midwives, the official podcast of the Journal of Midwifery and Women's Health, where we bring the pages of the journal to life. I'm your host, Melissa Avery. Each episode, we go deep into the evidence, spotlighting the researchers, the breakthroughs, and the midwives leading the science that is transforming reproductive health care. Greetings, and welcome to Speaking of Midwives with the Journal of Midwifery and Women's Health. Today, we are speaking with Ann Ledbetter, full-scope midwife at 16th Street Community Health Centers in Milwaukee, Wisconsin. We are talking about her article, Observed versus Predicted Vaginal Birth After Cesarean for Patients of a Community Health Center. This was published in 2024 and was a fascinating article looking at the right way to work with clients and counsel them about their options following a cesarean. Welcome, Ann.
Hi, Melissa. Great to be here.
Would you start today by just telling us a little bit about your midwifery background for our listeners?
Sure. I became a midwife in 2007, so almost 20 years ago. I've been working in the same place my whole career. It's a community health center in Milwaukee. The majority of our moms identify as Latina, so I do speak Spanish and interact with patients a lot in Spanish. I do full scope midwifery, so prenatal care, women's health, and then I attend births at a hospital. I really enjoy bedside midwifery, so that's kind of what I focused on throughout my career, but I also enjoy writing and research as well. So I have a Substack called A Moderate Midwife, where I publish something every couple of weeks. And then I've tried to participate in the Journal of Midwifery and Women's Health. I've published a few articles there as well. So I like to use my free time on research and writing because it feels like a way to influence more people on a larger scale.
Well, that's terrific. And we're so happy to have you as a participant in our journal. I was interested to learn about your Substack. And is that something that you said it was general, but I'm curious about the title of it. How'd you come up with that? The Moderate Midwife.
Yeah, good question. I think it's because I find midwifery is often associated with extremism. A lot of people hear the word midwife and they immediately go to home birth, natural. And yeah, I'm a big fan of that, but I also, as a hospital-based midwife, have a lot of experience helping moms along who do have, complications in their pregnancy. And I find that often when it comes to medicalized childbirth and versus, home birth and more physiologic labor, there's often, gray area and not one right answer. And so a lot of my Substack talks about topics where I think there's, multiple viewpoints that need to be considered.
That's great. I bet people find that really, really helpful to have a place to just go and find some information kind of from that perspective. Yeah. Well, let's talk a little bit about what led to your interest in developing this research project about vaginal birth after cesarean in your community setting.
Yeah, so, when I first started my career, a lot of people were using the original VBAC calculator, which included a race variable. And it always seemed just so unfair to me, especially because my patients were mostly Latina. Their scores were basically being systematically docked, for their race. And, in 2020, there were some important articles that came out challenging that sort of race-based medicine. And as a result, the authors of this calculator kind of created a new calculator based on the same data that they pulled from women who gave birth in 1999 through 2002. So basically using the same group of women who are attempting a TOLAC, they threw out a nomogram that included additional variables like chronic hypertension, but took away the race variable. And I wasn't convinced that this new calculator was going to remove the impact of race because it still relied heavily on BMI. And I could kind of tell from working with the patients that I worked with that it was their BMIs that was kind of making them seem like poor candidates for VBAC.
Yeah. Well, and of course, in the literature, as well as, ongoing study about vaginal birth after cesarean and what makes it safe and successful. Also, is a lot of literature about weight and how that impacts people's likelihood of a vaginal birth in general and a cesarean. So the two are quite intertwined.
Right.
And actually, you wrote, we're focusing on a particular article today, but you had another one earlier where you talked about how to advise patients of higher BMI.
Right. Yeah, I wrote a case study about a mom that I took care of who did have a higher BMI, and so I believe that her probability was in the 20s or something, but she went on to have a VBAC. Um, and yeah, cases like that, I just felt like I was seeing them a lot, and it kind of made me question the accuracy of the calculator and made me want to look deeper into, a larger scale.
Yeah, no, I understand. Anyway, you're building on that, and so let's back up a little bit though. And would you tell our listeners a little bit about the 16th Street Community Health Centers and the practice you're in? The midwifery approach there, how the midwives, the work of the midwives, and your approach to labor after cesarean.
Sure. I work at an amazing clinic. We are a very diverse group of midwives, and we serve a very diverse group of women. Um, we usually have between 10 and 13 midwives working in our
Wow.
practice. We attend between 600 and 800 births per year. We have some family medicine doctors who rotate in with us, and we also have OB attendings available in our 24/7 hospital setting. We work intimately with MFMs as well. Being a community health center, we do care for some higher risk patients. And our approach to labor after cesarean is very, I would call it supportive. We have a culture of supporting labor after cesarean and have had that for a very long time. Obviously, we leave it up to the mom what she wants, but I do find that the majority of moms we care for do want to try for a VBAC. And I think that's in part because we're very positive about it and supportive. And because of this approach, we attend a lot of labors after cesarean. Um, Over this 11-year study period, we were able to identify 507 labors after cesarean.
Wow. So just as a little sort of like a one-off, but in case any of our listeners are wondering, what is your approach to your patients that have had two cesareans?
So, this has changed over time. I found in the beginning of my career, most of the OBs that we worked with were pretty hesitant and
Yeah.
unsupportive. So, for a mom to try that, she would have to have like a really strong desire and even an ability to sort of go against medical recommendations. I have found that in more recent years, the obstetricians we work with are much more open to it. And so, yes, our study did include a few moms who had had two prior cesareans. And I think personally that offering this is super important because otherwise you see moms making some kind of not as safe choices, for example, to try to give birth at home after two cesareans.
Yeah. Yeah. Well, let's move on to talk about your study then a little bit. And can you start by just telling us the specific purpose of the study? What were you hoping to accomplish?
Yeah, so we wanted to assess the updated VBAC calculator, as I said, with attention to birth history and BMI. And because we had a predominantly Hispanic cohort, about 89% of our patients identified as Latina, we felt like it was a really good population to sort of test whether or not removing the race variable had sort of made the calculator more accurate. And as far as I know, we're the first to assess the calculator for women with a history of prior vaginal birth versus those without. So I don't think that's considered by a lot of the studies that I've seen. We compared observed versus predicted VBAC. So it's a pretty simple study design. We just collected all the data necessary to calculate a probability score, which includes, age, BMI, obstetric history, and in the case of the new calculator, history of chronic hypertension. And we calculated the VBAC probability score for each person who attempted a VBAC. And then we just compared that to our overall success rate. We also looked at BMI in 4 categories. So how accurate was the calculator when it came to people with a BMI less than 25, 25 to 30, and then 30 to 40, and then we looked at above 40. And then our final purpose was to ask the question of what would be the impact of discouraging labor after cesarean with a VBAC probability below 70%, because 70% is used in some of the literature as sort of it's thought to be sort of an inflection point where if you're below 70, you shouldn't attempt. And if you're above 70, then your chances are high enough to attempt.
And you approach that more flexibly.
Our group did, yes. We are not in the habit of discouraging moms based on their calculator score.
Mm-hmm. Okay. So then you were able to look at how many VBACs would have been predicted by the tool versus how many actually occurred.
Right.
Yeah. So tell us a little bit about what you found.
So we had higher success than was predicted. The average TOLAC probability score of our patients was 70, but our actual VBAC attainment was 82%.
Wow.
When we looked at specific categories, we found that our moms with no history of prior vaginal birth were much more likely to have a VBAC than the calculator predicted. The same was true of people with higher BMIs. So the only BMI category for which the calculator was accurate was the people who had a BMI of 25 or less. People who had a BMI of 25 or above statistically performed better or were more likely to have a VBAC than the calculator predicted.
Wow, that's really something. What happened when you all, calculated your results and shared them within your practice group? What was people's reaction?
Yeah, well, I don't think any of us were very surprised. I mean, like I said, we've been pro VBAC for a long time. I do think it was helpful information to have and to give to patients.
Hold it in your hand.
Yeah, I feel like, not everyone has that. Instead of the calculator, I felt like we were kind of able to use our own data to say, based on your individual situation, having not had a prior vaginal birth, your odds are about 70%. The moms who had a prior vaginal birth, their chances, they had about 92% VBAC rate.
So can you say a little bit more about what you found? I hope I'm asking this in a way that makes sense, but specific to the 70% typical idea of a cutoff, how did that work for you?
Yeah, so, our final question was, what if we as a group had discouraged VBAC attempts in anyone with a probability of less than 70? Well, out of the 400 individuals in our cohort, there were 83 who had more than one labor after cesarean during the study period. Many of those moms were people who in their first labor after cesarean had less than a 70% chance. So if they had been encouraged to just have a repeat C-section, that would have presumably led to them also having a C-section in subsequent pregnancy.
Right.
So we found that if we had discouraged those moms from labor after cesarean, it would have dropped our total VBAC rate from 82% to 39%.
Wow.
And it would have led to several moms who would have had higher order cesareans, people who had 3, 4, 5 cesareans. So we felt like this was a really interesting data point because it kind of shows how VBAC, while it has risks, also has the potential to prevent risks in future pregnancy.
Exactly, because we all know that the higher risks for people who've had multiple cesareans and then continue to have them as they plan their family. What recommendations do you have for clinicians then in terms of working with women with higher BMI? Because that was something else you paid attention to. Can you talk a little bit more about your findings and recommendations on that score?
Yeah, that was also one of what I thought was one of the most interesting findings. And I think, what has been well documented in the literature is that people of higher BMIs have less chance of VBAC. As far as I know, our study's the first to not show that. And you can see from our results that the chance of having a VBAC was pretty even in all the BMI categories. So my recommendation based on that is don't count people out based on their BMI. I'm not saying that BMI has no impact on birth or that our finding is generalizable to all populations, but I do think there's something to be said about the midwifery bias toward physiologic labor and our support of all different women of different body types. I think midwives just tend to have a belief that women are capable. And while there is a lot of bias against people of higher BMIs, I think that in my group particularly, we treated people in labor with higher BMIs the same way we would anyone else. You know, we were patient, we evaluated their need for Pitocin. We didn't recommend C-section if they didn't meet the definition of failure to progress. So I guess my recommendation is treat people of larger body sizes the same way you would anyone else.
Right. Yeah. Yeah. Are there policy implications, or what do you see as policy implications related to this work that you've done? And in particular, they're sort of broader, global. You've shared this information, but also, did anything change in your practice? And then what else at other levels of policy?
Yeah, that's an interesting question. I have been asked by a few people, well, if you don't think this calculator is working well, then maybe the calculator just needs to be fixed. And personally, I would love to get away from this way of thinking because I think that we as clinicians, midwives, doctors, leaders in our hospitals, we really need to spend some time thinking about the non-patient factors that lead to higher cesarean rates. Like we know that the cesarean variability in our country is just atrocious. Like it cannot be justified. So I don't think I don't think we can blame cesarean rates on patients. We need to start thinking about the way we behave in our hospitals, what protocols we're following. And I mean, also, I think it's interesting that the calculator is still based on births that occurred in 1999 to 2002. And I just doubt that these births are predicting modern day outcomes. We have some newer data stating that the rate of successful TOLAC has gone up. Like it used to be around 70%, now it's 75. So I think you can see ways in which clinicians are improving and are better able to help moms attain a VBAC. So I think as midwives, we just really need to beat that drum. We need to be the ones advocating for evidence-based protocols on our units. We need to increase our numbers because there are studies showing midwives are more pro VBAC than physicians. And I feel like the more influence we have, the more we can impact this problem.
Right. And as you said earlier, just take care of the patients, monitor their status, make decisions as you go, and you see how things are evolving.
Right.
And of course, with them involved, because a big part of this is the counseling and explaining the situation and helping people arrive at a decision that works well for them and their family. Can you say a little bit about that and how you all approach that in your practice?
Yeah, right. And, attempting VBAC isn't the right choice for everyone.
Right.
There are always going to be moms that don't want that. And that's fine. And we have to be supportive of that too. My patients often will choose a repeat cesarean. But I think on the other side of things, we have a situation where in many places in our country, even women who really want a VBAC don't have access to it because they're sort of forced to give birth at a hospital that doesn't allow it. And I hate to use that word, but it's true that hospital policies, physicians, midwives, we all have influence over what our patients have access to and what the ultimate outcomes are.
Right. Well, and as you said, the variation in cesarean rates and the ability to go to a hospital and labor after cesarean very widely across the country. And when there's no choice for people, they make other choices. And we've seen a lot in the literature about women choosing to labor at home with a cesarean because they have no other choice.
Right. Yeah. It scares me a little, to be honest. There's a lot of talk lately about free birth and free birth and even some home births where, the person maybe isn't a good candidate. I think we have to really look deeply at our medical system and to try to understand why people are making these choices and why they feel like that's the only choice they can make.
Right. Yeah. Well, I hope your study will make a difference in how some systems consider what's happening, because of course the individual providers and the group of providers are really important. But when the systems put things in place that prevent certain kinds of care from happening, obviously it makes a big difference. And so often we look at ourselves as individuals, but the systems are really what drives so much of what we do.
Right. They have a big impact.
Yeah. Yeah. Well, you wrote a letter to the editor to the American Journal of Obstetrics and Gynecology after your article was published, and based on what was published there. Can you talk a little bit about your message and why you did that?
Sure. So I wrote in response to a study they published, which basically was an assessment of the calculator similar to ours. And it had only a very small number of Black and Hispanic women in the study. I think it was like less than 90. And based on this small study, they concluded that the new calculator was sufficient, that it was doing a good job for people of color. So my response was to say, it doesn't really matter if this calculator is better than the old one, because VBAC rates for people of color are not going up since the new calculator came out. And my colleagues and I, having done this larger study where the vast majority of our moms were people of color, we found that the calculator performed pretty poorly on several domains. So my argument was that we can't just accept this calculator without studying the real world outcomes it produces. And based on my experience, the outcomes that calculator is going to produce will likely continue to discourage women of color because on average, they will have higher BMIs and more chance of chronic hypertension. So it may sort of inadvertently continue a sort of racial discrimination against women who might want to attempt labor after cesarean.
Mm-hmm. Now, I can't recall now. Was there a response back to your letter, and how did that go?
Oh yeah, their response was just thank me for acknowledging that. No real disagreement, but it was a productive collegial conversation.
Sure. So then that leads us to research. Like, what other research do you feel is needed, given the work you've done and what you see is out there currently in terms of the current state of the literature around this topic?
Yeah, that is a great question. And personally, one question I would love to answer is, how does having a midwife for your prenatal care affect your chances of VBAC? Because I suspect that it's not all about what happens on the labor and delivery unit. It's also about the encouragement or lack thereof you receive during prenatal care. And I'd love to do that study on a population similar to mine, where people aren't necessarily selecting into midwifery care, because I think we know that there's sort of a bias for women who really want a more physiologic experience, who really want a vaginal birth or a VBAC, are more likely to seek out midwifery care. But, my patients really aren't that way. They're using our community health center because it's in their community and they speak Spanish, and so do we. I don't think there's really a strong desire to seek midwifery care, but we do have a reputation of providing good prenatal care in the neighborhood. So I would love to find a way to separate, women who are seeking midwifery care and are therefore more likely to have good outcomes because that's what they really want, versus women who sort of end up in midwifery care, and how do their outcomes compare to people who, end up in obstetric care.
Yeah. Have you thought about how that might be done? Like, as you're talking, I'm thinking, wonder if, several health systems where midwives and obstetricians were practicing and, adjusting for risk factors, as you said, because we tend to, as midwives, to see a lower risk group of clients.
Right. Yeah. I would love to do that study. And I think it needs to be done. I think so much about the ARRIVE trial and how much attention it's gotten because it was an RCT, a randomly controlled trial. And so, of course, I wish that were possible to do with midwifery. And I feel like it is. There just isn't the political will, let's just say, to do that. But I also do think that retrospective trials have an important role, because I know they're sort of viewed as less accurate. There's less we can learn from them. But I feel like retrospective studies are looking at what actually happens in the real world. So I don't think it's a bad idea to do a retrospective study comparing like midwifery care versus obstetric care among people who come to clinics. Like, let's just say if we looked at all community health centers in the United States, well, midwives actually very frequently work at community health centers like mine. And I think it would be really interesting to compare, among similar patients, similar races, ages, BMIs, retrospectively, how are outcomes of midwives comparing to outcomes of obstetricians or family practice doctors.
Yeah. Right. No, I agree with you. I mean, there are many types of studies for many reasons. You can't always, I mean, if you randomize people to obstetric care or midwifery care, you take away a choice. And it's almost like the argument that's been made about studies related to water birth. You sort of take something away from people if you make them choose. And there are other ways to gather data. And then sometimes if you get data one way, then you can build on that with a different kind of study once you know a little bit more. So I agree with you. They're all valuable.
Right.
Yeah. Well, before I ask you for like a little summary and message to our colleagues that are listening, I wonder what did I forget to ask you? What else would you like to talk about this study and its importance? Because it's so interesting to me. I still remember the day I first read it and I was like, wow, this is terrific. And it's such a nice, example of clinicians doing research to further the work and the questions coming up from the clinical setting, which is so important.
Thank you so much. I mean, I guess I come back to the fact that we as midwives are with women, and it's our job to support what moms want. And obviously, not everyone wants a VBAC, and that's totally fine. But I think we also have to acknowledge that we have immense influence over a mom's decision-making process. Like, I know personally that I have patients who really could have gone either way on trying for a VBAC, and they tried because my colleagues and I consistently gave them the message that, hey, we think you're capable and we're here to support you on this journey. And so I wouldn't count out the influence of providers, midwives, doctors on improving VBAC rates. In fact, I think that is what is making a difference at this time. More midwifery care, rates of midwife attended birth are going up. And there's studies showing that proportionally midwives are attending more VBACs than would be predicted based on our numbers. So it's clear that women who want a VBAC are seeking us out, but I think it's also clear that we're supporting people both in prenatal care and during labor, and that this is having an impact of improved VBAC rates.
Right. And you talked earlier about just the change you've seen in your obstetrician colleagues in terms of supporting options for women that want it. And so it's always critical in these situations to have supportive obstetricians that we can partner with and work interprofessionally to, as a team, provide the best care.
Yes, for sure. I would not discount the amazing obstetricians out there that are very supportive of VBAC, and I've been blessed to work with many of them over my career.
Yeah,
that is very true.
So one other question, maybe I'd be remiss if I didn't ask you, were there any harms you discovered or any outcomes that were less than what you expected? Because you had such really interesting and positive results. Was there anything that didn't go quite how you thought?
No, we had one uterine rupture in 507 VBAC. So that was surprisingly low.
That was.
But of course, we didn't have a big enough sample size to really make any determinations from that. And I'm more curious about running more recent data on this, because I have felt that with the influx of patients coming from Central America, that we're seeing an increase in people whose cesareans were not well done, and that this is increasing their risk for, really bad adhesions, uterine ruptures. So I'm kind of curious if we were to do this with, I think our data stopped in 2022. If we were to run this again, I am curious what kind of uterine rupture rate we would get and if it would be worse.
Interesting. Well, when you get that figured out, let me know. We'll chat again.
Yes.
In the meantime, could you, before we wrap up our conversation, could you just give kind of your summary of conclusion or recommendation to our colleagues based on your work? What do you want to send people away with in a couple sentences today?
Well, my main takeaway for colleagues is just to continue believing in and supporting women. We know as midwives that women of all different ages, races, body types are capable of vaginal birth, and they deserve our support.
Well, that sounds like a good wrap-up comment. Thank you so much, Ann. I really appreciate the engaging conversation about vaginal birth after cesarean in a community health center. And thank you to our listeners for joining us on Speaking of Midwives. Please listen in next time. Thank you for joining us on Speaking of Midwives, brought to you by the American College of Nurse Midwives and the Journal of Midwifery and Women's Health. If you were inspired by today's conversation, connect with us through ACNM's channels. The Journal of Midwifery and Women's Health is at jmwh.org, your resource for cutting-edge midwifery and women's health research. See you next time.